Welcome, everyone. My name is Diego Relasua. It is a pleasure for me to share with you the results that our group has been working on for the past 2 years on COVID-19 vaccines, specifically on their efficacy in adults with Down syndrome, the duration of their effect, and the potential effect of confounders or different comorbidities that present with a wider prevalence in adults with Down syndrome. We were concerned about this because we knew that people with Down syndrome were at risk population for COVID-19 hospitalization and risk, and because we also knew that the immune dysregulation that the syndrome carries could entail an impairment in the generation of protective immunity. So to that effect, we undertook an observational longitudinal prospective study in adults that were consecutively recruited from those followed up at the adult Down syndrome unit of the Hospital Universitario de la Princesa in Madrid. Their vaccination schedule was done by the Ministry of Health, so we had no intervention there whatsoever. And as you can see in the figure number 1, we screened 158 subjects in baseline, that is before vaccination. Then we followed most of them 3 months after vaccination, 6 months after vaccination, and a significant amount of them, over 100, we followed also after the third booster dose. What we found in figure 2 and 3 was that adults with Down syndrome do develop a positive cellular and humoral antibody response and cellular immunity response, both 3 months and 6 months after the initial 2 vaccine regime. However, these antibody responses, you can see in figure 3, wanes over time, specifically or most significantly for those adults over 40. That is why we're also very interested in seeing what the results were after the third booster dose, which I present to you in figure number 4, where almost all adults with Down syndrome developed a positive CD4 cellular immune response, and also a significant amount of them, 29%, which is significantly higher than the initial 16% that we had in figure 2, 6 months after the initial vaccination. Well, as I said, a third of them developed a positive cellular immunity, CD8 cellular immunity after the third booster dose. And in a joint effort, which included also the Hospital Policlinico Gemelli and Bambino Gesù, both in Rome, we merged all our data to do a specific analysis of potential comorbidities that could influence this vaccine response, and we found no specific comorbidity that influenced the antibody titer 6 months after the initial vaccination, as you can see in figure 5, thus concluding that only age was the main variable that was linked to the antibody titer 6 months after vaccination. So to conclude, we could safely say that adults with Down syndrome do develop an effective immune response after the initial 2-dose regime of a COVID vaccination. However, this immunity wanes over time, just as it does in the general population, and the third booster dose is needed to prompt again a solid cellular and antibody response. And this is particularly needed in adults over 40, which are the ones in whom immunity wanes significantly faster over time. And we have found no specific comorbidities that influences this antibody response. So with this, I wanted to thank the whole group at the Hospital de la Princesa, including this Department of Immunology and Microbiology, as well as our funders, the Instituto de Salud Carlos III, European Union, and Fundación Jérôme Lejeune. And I also wanted to thank you all for your attention today. Hello, everyone. My name is Diego Realdesua, and I'm very happy to present our study on the evaluation of congenital and acquired heart disease in a Spanish cohort of adults with Down syndrome on behalf of my group at the Hospital Universitario de la Princesa in Madrid, Spain. What we wanted to do is to evaluate different aspects of cardiac and cardiovascular disease in adults with Down syndrome because we believe that current healthcare recommendations might not be appropriately tailored to our population of adults with Down syndrome. To that effect, we undertook a cross-sectional study of all adults that visited our unit between January 1st and December 31st, 2019, and we retrieved all clinical and demographic data from their electronic medical record. As you see in the center of your screen, from a general sample of 900 and close to 40 adults with Down syndrome, we had echocardiographic information available in 420 of them, of which roughly half of those adults had confirmed diagnosis of heart disease. As you see a bit under that flow chart, the study population had a high prevalence of weight disorders and obstructive sleep apnea. However, they had a very low prevalence of arterial hypertension or diabetes mellitus. Despite having these classic cardiovascular risk factors, we only found that 9 cases of cardiovascular events had been recorded in our follow-up, and that included no cases of ischemic heart disease, no cases of atherothrombotic cerebrovascular disease, and 9 cases of strokes, 4 of which were due to cardiac embolism, 4 due to moyo-moyo disease, and 1 was undetermined cause. So to this first part of our study, we can conclude that atherothrombotic events in adults with Down syndrome were practically non-existent, and thus we may have to think through the current recommendations, the current healthcare recommendations of screening and follow-up of classic cardiovascular risk factors in this population. On the other side of our study, we also looked at how prevalent congenital heart defects or valvular defects were. We found that the most frequent case was to have 1 congenital heart defect, mostly diagnosed in infancy, that accounted for 90 cases, or to have 1 congenital heart defect plus residual valvular disease, that accounted for 80 cases, 80 additional cases, but also 23 defects, which account closely for 10% of our population, were valvular defects that had been detected in adulthood. As you can see to the right of the screen, the prevalence of ventricular septal defects, atrial septal defects, or atrioventricular defects closely resemble those that have been described for the pediatric population with Down syndrome. And on top of that, we also describe how all sorts of valvular regurgitation were also prevalent in our sample, with mitral regurgitation being the most frequent type, followed by tricuspid regurgitation and aortic regurgitation. So as you can see, the prevalence of heart disease in adults with Down syndrome is slightly higher than that reported for the pediatric population, but because there is this additional prevalence of valvular disease that was not accounted for during infancy, we also believe that the management of cardiovascular disease in our population should also include universal echocardiographic screening for these adults. With these, I also wanted to thank my whole group for the effort in this poster, as well as the Instituto de Salud Carlos III and the European Union for funding us. And I also wanted to thank you all for your attention today.
Hello, my name is Dr. Amy Van Moorlen. I'm a pediatric endocrinologist at the University of Missouri. Today, I'm going to share my poster with you, A Curious Case of Puberty in a Male with Down Syndrome. Some background. Minimal studies exist in the literature about the age of onset of puberty in children with Down syndrome. There are even less reports available about precocious puberty. This is a case suggestive of central precocious puberty. Case report or background. A 10-year-old male with a diagnosis of Down syndrome who has been followed since 3 months of age presented to clinic for a follow-up visit for hypothyroidism. He's been euthyroid for the majority of time since his diagnosis. Mom reported that he's been having some behavioral issues at school. In addition, it's noted that he has an increase in his growth velocity. When asked about signs of puberty, Mom thinks that he began to have pubic hair growth at about 9.5 years of age. Therefore, we did a physical examination. His height on a Down syndrome growth chart was at about the 90th percentile, or 139.3 centimeters. His weight was at the 60th percentile. His GU exam showed that he had non-palpable bilateral testicles. He had no axillary hair. He was Tanner stage 2 to 3 for pubic hair development. When we looked at his growth chart, we noticed that he was having an increase in his growth velocity. Therefore, due to concerns about precocious puberty, an evaluation was started. We performed an LH, FSH, and testosterone levels, and those were in pubertal range. We performed a 17-hydroxyprogesterone level to evaluate for potential concerns about non-classic congenital adrenal hyperplasia. However, the level was not elevated. We also performed thyroid function tests, and they were normal. When we did a bone age, it did show that he had an advanced bone age. He had a chronologic age of 10 years and 6 months. His bone age was advanced and met standards between 13 and 14 years of age. We did a scrotal ultrasound. If you remember, we were not able to palpate his testicles, and it showed that he had undescended versus retractile bilateral testes. He was also found to have bilateral testicular microlithiasis. As part of the workup for precocious puberty, we did an MRI of his brain with and without contrast to focus on the pituitary gland. There was no evidence of pituitary gland abnormality. However, he did have dysgenesis and thinning of the posterior corpus callosum. Therefore, we also performed a full pituitary hormone investigation. This case highlights the importance of the GU prepubertal exam in patients with Down syndrome. Initial Tanner stage wasn't able to be performed in this case because of undescended testicles. His LH, FSH, and testosterone levels were in pubertal range, and he also had a bone age that was about 3 years advanced. Based on his advanced bone age, his predicted adult height on a Down syndrome growth chart is only going to be at about the 25th to 50th percentile. If you remember, he's currently growing at about the 90th percentile. In conclusion, few reports of central precocious puberty exist in males with Down syndrome. Given the increased occurrence of undescended testicles and patient anxiety towards exam, it might be difficult to perform Tanner staging. Therefore, if other signs of precocious puberty are present, such as an increase in growth velocity, central precocious puberty should be considered in the differential diagnosis. Given the association of Down syndrome with thyroid disease, it's also important to distinguish between central precocious puberty and peripheral precocious puberty. Long-standing severe primary hypothyroidism can also present with signs of puberty. These signs of puberty regress when appropriate treatment with levothyroxine is started and thyroid function is normalized. Scrotal ultrasound prevalence of testicular microlithiasis is also increased in patients with Down syndrome. They think there may be an association with this and the infertility seen in Down syndrome. Remember, if not caught early, central precocious puberty can continue to advance the bone age, which can further limit the adult height. Thank you very much.
Hi, my name is Jennifer Gray. I'm a speech-language pathologist, and I'm going to talk about an intensive voice treatment program for children with Down syndrome and the phase 1 outcomes of the researchers here below. I am an SLP that uses this program in my private practice for those with Down syndrome. Here are some financial and non-financial information about me. This study is the first to examine the effects of LSVG loud on children with Down syndrome and motor speech disorders. It stands for the Lee Silverman Voice Treatment Program. It is designed to help individuals originally with Parkinson's disease and other neurological conditions improve their vocal loudness and communication abilities. The LOUD program is based on the principles of neuroplasticity, which suggests that the brain can adapt and change in response to targeted exercises and stimuli. For those with neurological impairments, The program also involves intensive one-on-one therapy sessions that focus on improving vocal loudness through sustained phonation and high repetition of words and phrases. There are cross-system benefits of focusing on vocal loudness that include improved articulation, reduced speech rate, breath support, and confidence to communicate with others. The factors that affect speech and language delays and disorders for those with Down syndrome are complex. They have multiple speech delays and disorders simultaneously, including articulation, phonology, motor speech, motor planning disorders, dysarthria, fluency, and voice disorders. Voice resonance and fluency disorders impact speech clarity throughout the lifespan, but are rarely directly treated. And it is estimated that those with Down syndrome only receive about 10% of the recommended dosage for speech therapy. And they are not given adequate speech practice throughout the lifetime. The omission of adequate speech practice leads to more severe speech and behavioral challenges in later years. Those with Down syndrome have speech and voice characteristics similar to other group of children who have been using LSVT Loud, such as those with CP. It uses simple and consistent cueing system that is ideal for those with poor short-term memory, that reduces the cognitive load associated with retrieving, planning, and executing speech for language use. And that simple cueing system involves using a loud voice or saying it like me or do what I do. It is 4 consecutive days a week for 4 weeks in a row, so 16 sessions for 60 minutes each. It is individual, not group therapy. They have daily homework practice and daily carryover exercises all 30 days of that month. And it must be delivered by an LSVT Loud certified speech therapist. There were 9 children ages 4 to 6 years with Down syndrome who participated and were tested before and after completing LSVT Loud. They measured intelligibility, vocal functioning, and parent perceptions of communication function. And they wanted to know whether or not children with Down syndrome would tolerate the full dose of LSVT Loud, would adhere to daily practice, and would exhibit similar positive changes in speech and voice as previously reported in those with cerebral palsy. The results: all children completed the full dose of LSVT Loud and showed gains in 1 or more of the outcome measures. Parents liked the treatment protocol, perceived benefits from the intensive intervention, and indicated they would recommend it to others. It showed that children with Down syndrome tolerates intensive voice treatment without adverse effects and made meaningful therapeutic gains. It suggests that LSVT Loud might be a viable treatment for those with Down syndrome. What are the limitations of this study? It's the first one to look at intensive voice therapy for those with Down syndrome, small sample size, no control or comparison group, and determining if LSVT Loud is as effective as other treatments is yet unknown. Tolerance and intensity of frequent therapy was consistent across participants, but outcomes were variable. There are no other voice treatments for comparison, so we can't really compare the two, or 3 or 4, and research in motor speech disorders, childhood apraxia of speech, and fluency disorders are the only other areas of research that use repetitive, frequent, and intense speech practice that we can look at. Because speech and language are so complex, we tend to discount the abilities of those with Down syndrome and expect less from them. This study is one small step demonstrating that those with Down syndrome can tolerate intense interventions and benefit from them. Thank you very much.
Hi, everyone. I'm Dr. Amy Lawanda, and I'm here with Monica Forker and Margot Rondo to present our poster, 321 Go, a program to promote healthy lifestyles for individuals with Down syndrome. People with Down syndrome are 2 times more likely to have obesity, 2 to 4 times more likely to have diabetes, and 27% more likely to be diagnosed with depression. In addition, there's a 90% lifetime risk for Alzheimer's disease. Physical activity, nutrition, and emotional well-being are lifestyle factors that can mitigate these chronic conditions. However, people with Down syndrome typically do not meet physical activity or dietary guidelines, have sleep issues, and use avoidant coping strategies when dealing with stress. Physicians monitor health indicators like blood pressure and weight status, yet strategies for behavior changes are rarely addressed within routine visits, mainly due to time constraints. Studies have shown that behavioral changes programming is an effective approach for improving health. Providers can recommend behavior change programs, but are not always certain which programs are catered to their patient needs.
321GO is a program developed by the National Down Syndrome Society that encourages individuals with Down syndrome to live a healthy life, including physical activity, balanced nutrition, and emotional wellness. Pictured here is the 321GO program guide, which includes educational materials on these 3 areas of wellness. The foundation of the program are the 3 daily goals that you see here. The guide includes a weekly tracker to track progress towards these goals, and additional trackers can be downloaded from our website for free. Additionally, for anybody needing support meeting their fitness daily goal, we have a fitness kit that includes equipment pictured here, the 321GO guide, and a series of exercise cards. The exercise cards include 64 safe and effective exercises with photographs of individuals with Down syndrome providing demonstration. For families looking to support 321GO, we also have 2 resources, a one-pager that includes tips for support and a family health calendar that has a challenge for each month of the year. The NDSS program was originally designed for adults with Down syndrome, but we recognize the need to support adolescents as well. Additionally, we feel physicians can be great motivators to join this type of program.
With this in mind, we propose the following aims for our project. First, to introduce the 321GO program to adolescents and their families through the Children's National Rare Disease Institute. Second, to conduct a needs assessment of adolescent patients with Down syndrome and their families to better understand how the program might need to be adapted or what additional resources are needed. Third, to develop additional program materials based on these results to effectively deliver 321GO through Down syndrome clinics. And fourth, to pilot the 321GO program with adolescents with Down syndrome to assess changes in knowledge, self-efficacy, behavior, and health. We propose a multi-stage strategy to accomplish these aims. First, we will conduct a survey of families of patients with Down syndrome aged 16 to 22 registered with the Rare Disease Institute. Families will provide feedback on the health behaviors in which their adolescents need the most support, the types of resources and delivery channels that work best, and the likelihood that they would join the program. Using these results, additional resources will be developed. Educational materials will be created to inform providers so they can introduce 321GO to their adolescent patients. Finally, the program will be piloted with 20 patients with Down syndrome, 16 to 22 years old, using a one-group pre-test, post-test design. Changes in knowledge, self-efficacy, and social support will be assessed through a survey. Physical activity and sleep will be measured with a wearable device. Height and weight will be assessed on a physician-grade stadiometer and scale. This project will allow for adaptations to the program to ensure it is suitable for adolescent age groups and can be offered through clinical settings. Provider educational materials will help physicians bridge the gap between regular checkups and wellness support. A successful pilot could indicate the program is ready to be expanded both within Children's National Hospital and to other Down syndrome clinics serving adolescent patients. Thank you for listening to our presentation. If you'd like to learn more about 321GO, you can visit our webpage or contact us at the email address on this slide.
Hi, my name is Michaela Schaefer, and I am a member of the Massachusetts General Hospital Down Syndrome Program Team. Today, I'll be presenting on Down Syndrome Health Instrument Survey recruitment approaches. This project is based on a larger study that aims to assess the health of individuals with Down syndrome, and the study at hand aims to assess caregiver response rate to survey recruitment approaches. For the background of this study, of this project, studies have shown that surveys continue to be a common way to assess public health, and with growing technology, there has been a significant shift from using paper surveys to electronic surveys. Electronic survey collection shows benefits including collecting responses from a broad geographic area and convenience for survey respondents. In general, survey completion rates of 3% are seen for electronic surveys. The methods of this project were broken down into two components: development of the survey and survey recruitment. For development of the survey, an online survey was developed and launched using REDCap. Participants included caregivers of individuals with Down syndrome younger than 22 years of age who were fluent in spoken and written English. Participants were asked to complete the same survey 2 weeks following their first submission, and teachers and PCPs of the individuals with Down syndrome were asked to complete surveys as well. The caregivers, teachers, and PCPs received compensation for their participation. Survey recruitment: the survey information and link was shared with Down syndrome affiliate organizations, which we can see in table 1 below. The moderators of these organizations were shared the survey information and link with their members through email and private groups on social media platforms, including Facebook. A survey recruitment flyer in figure 1 was shared in person and mailed to families of individuals with Down syndrome at the MGH Down syndrome program. After April 24th, a source code was added to the survey links to track the sources of our enrollment. So now on to results and conclusions. In figure 2, we see that the number of people who completed each stage of the survey, there were 1,640 total survey respondents and 300 surveys complete. So in our first 300 completed surveys, there has been a 18.3% survey completion rate. The most significant drop in participation occurred at the consent step, with 363 people choosing not to continue the survey at this step. And so now I want to jump down to figure 7 at the bottom. This is the survey completion from February 7th to June 6th, 2023. This graph shows the number of surveys completed each day with the date of recruitment initiatives as well. So approximately 56,500 reported contacts received our survey information electronically, with only 1,640 people starting our survey. So 2.9% of people who received our survey information electronically started the survey, with even fewer completing the survey. So surveys completed electronically versus by paper and pencil is shown in figure 3, and 4 eligible participants requested paper surveys, with only 1 being returned. All other surveys were done electronically. Figure 4 shows survey enrollment from the Down syndrome affiliate organizations from April 24th to June 6th. This is when the source code was added to our survey. And based on this data, about 300 paper recruitment flyers were mailed or given to families with individuals with Down syndrome under the age of 22 in clinic, and 10 participants enrolled from this source. So 3.3% of people who received a physical copy of our survey information completed the entirety of the survey, and completion rates from people who heard about our survey from paper information flyers were higher than completion rates from people who heard about our survey through electronic versions of our flyer. And this is a common trend according to previous studies, which suggest that people feel more obligated to participate in surveys when they are approached in person. And other studies suggest that email surveys have lower response rate because the messages are disregarded as spam mail before they're even read. So figures 5 and 6 break down the demographics of our participants. Figure 5 is by race, and figure 6 is by state in which they live in. So some of the challenges that we faced in this project is on April 23rd and June 2nd, 2023, bots completed our survey, leading to inaccurate survey responses being recorded. Bots included computer-generated responses or people with false identities in efforts to receive payment. And so how can we use this information going forward? We want to explore strategies to increase interest in survey participation and consent from eligible participants. We want to investigate further bot prevention in addition to CAPTCHA techniques. And we want to compare additional methods of recruitment to increase survey enrollment and reach more diverse populations. So lastly, I want to give thanks to all the patients and families in the Mass General Hospital's Down syndrome program for their participation in this and other research projects, to the Down syndrome affiliate organizations listed in Table 1 for their recruitment efforts and continued support, and to the MGH Down syndrome program research team for support in drafting this poster. Thank you.